Hi, I'm Sudarshan Rajagopal. I'm co-director of the Pulmonary Vascular Disease Center and assistant professor of medicine and biochemistry at Duke University Medical Center. Today I'm going to talk to you about some of our research on hyperpolarized xenon MRI in differentiating diverse cardiopulmonary diseases. Meet Mysterious Mike. He's a 65-year-old gentleman, very typical patient that we would see in clinic. He has a 40-pack year history of smoking. He has COPD, is on an inhaler for that, but has also been told he has scarring in the lungs. He is obese, he has hypertension and diabetes, and he recently had an echocardiogram that showed pulmonary hypertension. So again, this is a very typical type of patient that we see in our clinic. How can we determine why Mike is short of breath? There are multiple reasons why he would be. So pulmonary hypertension, which is what my clinical focus is a disease of the blood vessels in the lungs that leads to high blood pressure, defined as a mean pulmonary artery pressure of greater than 20 millimeters of mercury. And what this leads to is that in a normal heart, the right side of the heart pumps blood through the lungs, but pulmonary hypertension with this high blood pressure in the lungs, this is due to a disease of the pulmonary arterioles that, again, results in high afterload here that makes it difficult for the right side of the heart to pump blood. This causes right ventricular hypertrophy or thickening and dilation and then failure, and ultimately death. And there are many causes for pulmonary hypertension. Pulmonary arterial hypertension is a very rare disease, but a disease which we have many treatments for, and that's a disease of the pulmonary arterioles here. But the most common cause is actually pulmonary hypertension due to left heart failure. And this can be due to weakness of the heart, like systolic heart failure, or in preserved ejection fraction. Lung diseases such as COPD and IPF can also cause pulmonary hypertension just by damaging and scarring the lungs. Chronic blood clots can cause PH just by obstructing the flow of blood through the lungs. And then there are a variety of other causes such as sarcoidosis and sickle cell disease that can all cause PH. And what we're seeing in our clinics now is that patients who are referred for an evaluation for PH are older and sicker with multiple comorbidities, and it can be very challenging to identify why they have PH. So again, figuring out shortness of breath can be really challenging, and this has led to the proliferation of dyspnea clinics. And what we see here, this is from a recent review in Circulation. These dyspnea clinics will perform a good deal of cardiac and pulmonary testing. This will include advanced imaging, invasive hemodynamics, and other studies. And then taking all of these studies together, they will try to essentially figure out why this person is short of breath. But frequently, we're left in a situation where it's really unclear. Could a new technology such as hyperpolarized xenon MRI imaging be helpful in this situation? So the current diagnostics that we have in pulmonary hypertension all have limitations. The gold standard here in your upper left is right heart catheterization. This is an invasive procedure where we actually go in with thin tubes into the heart and measure the pressures inside the heart. But at the same time, this is really lacking the physiologic context. The patient's usually sedated for the procedure, they're not exercising, and so the numbers sometimes don't correlate with what's actually happening when they're active. Echocardiography, shown here in the top right, is essentially ultrasound of the heart, and this allows us to get pictures of the heart, to estimate the pressures inside the heart, but again, it really doesn't give us the etiology or why this is actually happening. With pulmonary function tests here in the middle, we can see the diffusing capacity for carbon monoxide correlates with the pulmonary arterial hypertension, but it's a difficult maneuver, highly variable, and it doesn't give us regional specificity. And then other imaging technologies, such as CT scans or X-rays, allow us to see the lung parenchyma, but don't provide any information on physiology, while ventilation perfusion scintigraphy can allow us to assess for blood clots, but really isn't quantitative and does not tell us about, microvascular disease. So what we, in collaboration with Dr. Driehouse's group at Duke, is been trying to do or try to see if pulmonary hypertension, the different forms of it, could have different patterns in hyperpolarized xenon imaging. And so, as you can see here from these healthy images from a healthy cohort of patients, a cohort of patients with COPD, and one with IPF, they have very different imaging characteristics. COPD primarily has abnormal ventilation. IPF primarily has an increase in barrier signal, as shown by this purple signal here, which is just very high barrier. And then if you look in the healthy group, obviously, they're green all throughout. And so what's underlying these imaging characteristics? And obviously in the healthy patients, you have normal alveoli, you have normal blood vessels, and you get normal signal, green throughout. In the COPD patient, you have a loss of ventilation to a good deal of the lung, and that leads to the abnormal ventilation parts here. And in IPF, you have scarring or an increase in interstitial tissue, so you get an increase in barrier signal. When we look at patients who have left heart failure or pulmonary arterial hypertension, these defects are much milder than what we see in these other lung diseases. What is most notable is a decrease in red blood cell transfer signal, which essentially means is that we're not getting as much oxygen, or in this case hyperpolarized xenon, into the blood vessels as we should. But it's not a specific change on this imaging. So again, this is just quantifying some of these defects. You can see that the ventilation defect is very sensitive for and unique for COPD. The barrier defect is actually present in COPD as well, likely due to destruction of the interstitial tissue as well. While if we look for high barrier regions of the lung, we really see that only in IPF. And if you look at red blood cell defects, we see these across all the different lung diseases. The only ones where we see normal signal is in the healthy patients. But from the imaging alone, we really don't have any criteria that could help differentiate left heart failure from pulmonary arterial hypertension. And to address this issue, Bastian's group has been really at the cutting edge here in using hyperpolarized xenon dynamic spectroscopy, which is probing gas transfer at the alveolar capillary interface on the timescale of the cardiac cycle. So if we look here at a healthy patient and then an IPF patient, we can see this red blood cell signal. You have an increase in signal, and then you see it slowly decreased in the dynamic spectroscopy, and you see these oscillations during the decay. And these oscillations are actually due to stroke volume. So this is essentially the right side of the heart pumping blood into the pulmonary capillary blood volume, and you're seeing that change in the red blood cell signal. And you can see in IPF, again, similarly, you see this increase or this pulsatility in the signal during dynamic spectroscopy. Now, if you take this signal, you can then detrend it and fit it to a sine wave, shown here. And you can then fit essentially an amplitude to this and a frequency, and you can figure out quantify these cardiogenic oscillations. And so, we'll let it go through this animation here. These are the signals that we see for detrended signals for these different disease states. So you can see in a healthy patient, you can see these oscillations and this change in amplitude, again due to the cardiac cycle. In COPD, this is decreased. In IPF and left heart failure, it's significantly increased, while in pulmonary arterial hypertension, it is significantly decreased. Now, notably in IPF, what's unique in IPF compared to the other disease states is also a shift in this signal. But I won't get into that because it's actually not so helpful in differentiating these other disease states. But what you can see from this is that the pulmonary arterial hypertension and COPD are the only disease states that are associated with a loss in RBC amplitude oscillation. So this can help differentiate PAH from left heart failure. And when you think about the physiology behind this, this actually does make a good deal of sense. In left heart failure, this is, again, driven by pulmonary venous hypertension or high blood pressure in the pulmonary veins. So in this situation, what you expect is a downstream impedance. So you're going to have actually a significant increase in the pulmonary capillary blood volume with each cardiac cycle. But in pulmonary arterial hypertension, what we have is an impedance, an upstream impedance, due to a defect in the pulmonary arterioles. So now during the cardiac cycle, you have a decrease in this pulmonary capillary blood volume. So really, this dynamic spectroscopy is informing us on the hemodynamics underlying these disease states. So if we combined xenon MRI imaging at the top left with our xenon MRI dynamic spectroscopy at the bottom left, what we end up with is a panel of parameters that we can develop unique signatures for different disease states. If we plot these parameters out on a radar plot, as you can see here on the right, you can see that each disease state really has a different signature. In a healthy patient, we expect to see normal amplitudes and otherwise no significant defects or high barriers or shifts in oscillations. But in our COPD patients, we see both defects in ventilation and barrier, as well as in red blood cells. In the IPF patients, we see a high barrier and both a shift in their oscillations and an increase in the amplitude of their oscillations. In left heart failure, we see an RBC defect and then an increase in amplitude of their oscillations, while in the pulmonary arterial hypertension patients, we see that same red blood cell defect, but now we see a decrease in their amplitude of their oscillations. So again, each of these disease states has a unique signature associated with it. So how can we apply this technology? So again, being in a pulmonary hypertension clinic, frequently we end up seeing patients who are dyspneic or short of breath, and it's really unclear why, and we have to figure it out. So here are a couple of examples of sort of what we call zebras, and clinically, these are cases which are very difficult for us to figure out despite extensive testing. So here are an example of two patients who we saw in our clinic who, despite sort of the conventional studies, it was really unclear as to why they were so short of breath. The first patient was a 70-year-old gentleman. He only had a history notable for allergic rhinitis. He had shortness of breath and exercise limitation. He had a normal chest x-ray, normal CT scan, normal VQ scan. But his echocardiogram was consistent with mild pulmonary hypertension. And then he also had a right heart catheterization that really had what we call borderline hemodynamics, the mildly elevated pulmonary artery pressures. So it was unclear, again, why he was short of breath. But on his xenon MRI imaging, we could see profound red blood cell defects. And then our second patient here, patient number 2, was a 61-year-old non-smoker, and she presented with dyspnea and also had an oxygen requirement, needed 6 liters. She had a normal chest x-ray, a normal CT scan, and then she also had a normal right heart catheterization. So it was really, again, unclear as to what was causing her to require this oxygen. So she underwent MRI imaging, and again had significant red blood cell transfer defects and a very high barrier signal, like one would see in IPF. However, when we looked at their dynamic spectroscopy, you can see, again, very different patterns. In patient 1, you can see that the amplitudes in their red blood cell signal are flattened out, barely visible, while in patient number 2, she had marked oscillations in her dynamic spectroscopy consistent with very high amplitudes. Now, again, both of these patients underwent further clinical evaluation. For the first patient, this ended up with a surgical lung biopsy to try to figure out what was going on. And he ended up having a very profound pulmonary vasculopathy consistent with pulmonary arterial hypertension, which, looking back at it, one would expect from his xenon MRI scan. And if you look, when we looked at patient 2, her clinical condition continued to deteriorate. She could not get a biopsy, but she was able to get a lung transplant. And on the explanted lung, we observed that she had pulmonary veno-occlusive disease, which is a very rare disease of the lungs in the pulmonary venules. It leads to obstruction of those pulmonary veins. And again, with that post-capillary cause for pulmonary hypertension, we would expect to see very high amplitudes. So again, consistent with what her xenon MRI scan showed. When we do the dynamic spectroscopy, you can see in patient 1 how markedly reduced the amplitudes are. You can barely see these cardiogenic oscillations, while in patient number 2, they were markedly increased. And the first patient actually ended up getting a surgical lung biopsy because we were unclear as to what was going on based on his presentation, which clearly showed pulmonary vasculopathy consistent with pulmonary arterial hypertension. While the second patient developed worsening hypoxemia to the point where she required a lung transplant. And on explant, her sample demonstrated pulmonary venous occlusive disease. This is a very rare disease of the pulmonary veins that causes occlusions. And again, with this downstream obstruction of blood flow, she ended up with these markedly increased amplitudes in her cardiogenic oscillations. And we've published these 2 case reports. So what I think, where I feel like this hyperpolarized xenon MRI technology has a place is really in developing a comprehensive cardiopulmonary exam and working up patients with pulmonary hypertension and with unexplained dyspnea for any cause. It displays unique signatures for different cardiopulmonary diseases. The hyperpolarized xenon MRI is simultaneously sensitive to small airways disease, interstitial thickening, such as an IPF, capillary level perfusion, and pre- and post-capillary hypertension. It allows for quantification, unlike many of our other tests. And again, it can help differentiate pre- and post-capillary hypertension, which clinically is a major problem for us in the PH clinic. It's non-invasive, no radiation, no injection, and it also has the possibility of repeated scans for follow-up or assessing therapeutic response. So the next steps that we're pursuing right now from a research perspective is in correlating these dynamic spectroscopy changes with hemodynamics from the same day. So getting a right heart catheterization on the same day that a patient gets one of these scans. And then we're also testing therapeutic response. So some of the drugs that we use to treat pulmonary hypertension have a very short half-life. They have an immediate effect. So we're testing whether we can visualize that effect using this technology. This project is a longstanding collaboration between our groups in the Pulmonary Vascular Disease Center and Bastian's group in the Department of Radiology. So I'd like to thank a number of people. Obviously, Bastian's who's been critical in developing this technology. Most of the work here that you've seen on these images has been done by Ziyi Wang and Eliana Beer, who are two outstanding graduate students in Bastian's group. I'd also like to thank our funding from the NIH and the NHLBI, including the Vascular Innovations and Therapeutic Advances Group.